No disclosures. So this patient is a 9-year-old who presented to the orthopedic surgery clinic with scoliosis. When she was there, they did a detailed history and physical exam, and they found that she had persistent nausea and vomiting for many years. So they have their routine scoliosis films, just some mild scoliosis, 19 degrees. But in our orthopedic surgery clinic, we sometimes have screening of patients with scoliosis. Patients who are prone to have intraspinal pathology tend to have early onset scoliosis. So this patient is 9 years old, patient is less than 10, possibly. A severe curve, greater than 45 degrees. An atypical curve pattern, just curvature to one side. A rapidly progressive curve, maybe more than 1 degree per month, or some abnormal neurologic findings. Now, because this patient had early onset scoliosis, she had imaging and she was sent over to our clinic. And we did an even more detailed exam. And of course, we found a left upper thoracic prominence on the Adams-Ford bend test. So we had her lean forward. We can see the hump in her back. We found that she had brisk reflexes in her lower extremity and the right upper extremity. And so when I see that, I think there's going to be some pathology either in the cervical spine or the brain. She had diminished reflexes in the left upper extremity. And she had diminished sensation to pinprick below the right clavicle. So with this loss of painful sensation, now I'm localizing this to her cervical spine. And she's 9 years old, so she didn't cooperate with examination of a gag reflex. That happens. So here's where the screening MRI. You can see in the study that she has a holocourt syrinx, fluid all the way up to the brainstem, encompassing the entire spine, and she has a thoracic spine MRI. It goes all the way down to the 11th thoracic vertebrae. And if you look at the craniovertebral junction, you see some crowding, tonsil descent down to about C1. So, of course, she went to the operating room, and this was her procedure. She had a posterior fossa craniectomy, and the bone was taken from the base of the skull up to the inferior nuchal line, about 3 centimeters. A wide decompression at the foramen magnum, approximately about 3 centimeters or so. And the superior portion of C1 was removed. This provides an adequate decompression along with removal of the epidural compression band. And now after that's done, an ultrasound is performed, and based on the ultrasound, we may or may not open the door. In this case, the door was opened, especially with this holocourt syrinx. And she had an intradural lysis of adhesions. You can see just a bit of the bands that were lysed there. And on this picture, you can sort of see where the right cerebral tonsils coagulated to shrink the tonsils down. These pictures are from my colleague Brian DeLuis's paper, just published recently, the technique for harvesting cervical fascia and using it for DURAPLASTY. So this is a piece of her own cervical fascia, about 3 by 2 centimeters, sewn in place with interrupted sutures to get a watertight closure. So this is her MRI about 6 months afterwards. You can see a dramatic reduction in the syrinx. It's still there, dramatic reduction. If you compare the pre-op to the post-op studies, you can see very clearly this patient is improved. Smaller syrinx, decompression at the foramen magnum, and the patient's doing well. So you may think that's the end of the story, nothing else to do. But she comes back 4 years later with some new symptoms. She had nausea and vomiting at her original presentation, and the family knows that there's something wrong because she's not eating like she usually does. She typically eats this, eats that, and now she's slowing down. What's wrong? So we have this MRI, and the syrinx is back all the way up to the base of the skull. Now, in this picture, you see some tonsil descent, but it's not as crowded as before. So we had a CT scan done, And you see this is an adequate decompression. You see a small portion of C1 left as intended and a wide decompression at the base of the skull. These two bright spots are artifact from a hemoclip for hemostasis. So this looks good. So with that picture, we want to be getting a cine flow study MRI. These have been shown earlier today, so you may have an idea what we're looking at here. This is spinal fluid in front of the brainstem and spinal cord, spinal fluid behind. To get you oriented, you can see a bit better where we are. Brainstem, spinal cord with syrinx, cerebellar tonsils. So back to this picture so you can make everything out. So we're looking for, with this cine flow study, whether or not there's a block of spinal fluid at the base of the skull. So with this picture, you see that there is a bit of fluid there. It's not completely blocked. I'll show it one more time. Again, some flow posterior and anterior to the brainstem. So the question is what to do with this patient. New syrinx, new symptoms. She went back to the operating room for a C1 laminectomy, opening of the dura, extensive lysis of adhesions, and a DURAPAIR DURAPLASTY to expand the opening. This is an MRI 8 months post-op. Improved again, but not completely resolved. Lots of space at the craniovertebral junction. Then 3 years post-op, the syrinx is close to resolved, and again, lots of space. This patient was, to me, interesting because that was an unexpected result. After decompression, opening the dura, shrinking the tonsils, the syrinx gets better. I expect that patient to go on, be happy, live a good life. But she had recurrent symptoms. She had that syrinx. And if you look at those images, it didn't look like her craniovertebral junction was extremely crowded. It was tight, but not extremely crowded. So if you look at the literature, I was curious about this patient. What do we expect? What do we see? And this is kind of what you see over a large number of papers after surgery. This is an immediate post-op study. You see that most of the patients have either decreased or total collapse of the syrinx. Occasionally it's unchanged, and for this study, one was increased. You can argue why this happened. And so there are not many publications talking about a recurrent syrinx late, but there is one, and their story is an adult patient in the 30s. Same thing. Tonsil herniation, spinal cord syrinx, not as bad as ours, but it's essentially the same story. Post-surgery, nice decompression, improvement of the syrinx. You think this person's fine. But again, 30 months later, almost 3 years, the patient comes back with a syrinx. Now this is a CT scan, a CT myelogram, not a cine flow study. So they injected dye. You can see this white sliver of fluid, that's spinal fluid, but that's the dye in front of and behind the spinal cord. And you can actually see some of the dye behind the cerebellum. Now this was a phase contrast study, so they report that this filling happened a little late, but there's still some flow. So they took this patient back to the operating room just like ours, opened the dura, and found again lots and lots of adhesions. They wanted blicing. And the patient improved. So the thought behind this is, if the person has a recurrent syrinx, what should you be looking for? Well, the extent of bony decompression. Now, there are some people with a persistent syrinx and sometimes a recurrent syrinx, and sometimes what you can have is maybe just didn't decompress enough bone. You didn't go far enough for lateral. When we do this, we're very careful to go out to the sides and get this bone that's sort of indented into the cerebellar tonsils. An intra-arachnoid exploration, whether that's done or not, tonsillar resection or tonsillar shrinkage, lysis of adhesions, untethering of the spinal cord or the cerebellum, whether or not there's a dural expansion graft, and the type of closure. So that's what you should be paying attention to if a person comes back with a recurrent syrinx. Now, this is for a persistent syrinx, but same story. They approach this by placing a SYRINGO-SUBARACHNOID shunt, which worked for their patient, and this shows their intraoperative photographs with the patient lying down flat on the table with their head in this direction, feet in this direction. The dura is opened, and you see this expanded spinal cord. You can see here that the midline is coagulated, and they're starting to open up the midline with a myelotomy. They have accessed the syrinx. You can sort of see the fluid coming out there, and place a small catheter into the spinal cord and secured in place with a small stitch. These were their results. I'll point out there's a lot of stuff here, so I'll point out just a couple of things. You can get reduction in the size of the syrinx when you do this. For this, 60, 70, 90% reduction in the size of the syrinx. Over multiple levels, the syrinx comes down in size. And they report no complications. No complications after what looks like a pretty invasive procedure. Just a wounded hissing, neck pain, but nothing major. But if you look a little carefully, they also report some outcome scores here. This is a modified Japanese Orthopedic Association scale, and this is a percent change. You can see a couple of the patients have declined, over just a small number of patients. A couple of patients have a pretty dramatic decline in their functional status after this procedure. So this I have a little bit biased toward. Some people may not agree. I have a little bias toward Gore-Tex grafts versus pericranial grafts. In this paper, is publishing what they say. There's two surgeons, one who prefers Gore-Tex, another just pericranial graft. They reported the results afterwards. Cine flow study like we saw before, spinal fluid in front, and you see a bit of flow behind. With the pericranium, not as much. Maybe it's tighter in the back with a pericranial graft versus Gore-Tex. And for the significant results, the only thing they can report is this change in the hindbrain space. As far as outcomes, revisions, you can't say it's significant, but maybe there's a trend towards more revisions, but that may not be really significant. So there are not many publications on recurrent syringomyelia, and the take home from this is you'll see lots and lots of adhesions in these patients. But the workup should be the Cine flow study. It may underestimate the amount of flow. You could get a post-myelo CT scan. From my standpoint, that's pretty invasive to have a person with a needle on their back, and it's kind of painful. If you see them right afterwards, patients, they really complain about this. I prefer to have a less invasive study. And then you should consider re-exploration, opening of the dura, lysis of adhesions, before any shunting procedure, because you can get good results just by doing this. The lesson that I have from this is re-image patients with evidence of recurrent symptoms. So a person comes back, you think you've done a beautiful job, and they have some new symptoms. It is possible maybe there's recurrent pathology, maybe there's some scarring, maybe more needs to be done. And with that, I thank you.